Hey girlfriend, this is Jan James. Welcome to the Hope After Breast Cancer podcast, where women who have endured breast cancer learn to have fulfillment over frustration, clarity over confusion, and faith over fear. We tackle the issues that many of our sisters face after a breast cancer diagnosis, from brain fog to fear of recurrence, from menopause to sex after breast cancer. This is the place to learn how to have hope after breast cancer. So strap yourself in. Welcome to the Hope After Breast Cancer podcast. Hi, old friend. How are you?
Well, hi. It's been too long. I'm great. How are you?
Doing really well. Thank you so much for taking the time today. This is really exciting. And I've been wanting to get you, you're busy lady, for a long time. So anyway, so ladies,
Well, I'm happy to do it.
thank you. Let me introduce you to Dr. Lyndsey Harper, who is an OB/GYN out of Texas, US. And Lyndsey is also the founder of Rosy Wellness. And so, Lyndsey, tell everybody a little bit about your background in the Rosy story and how that all came about.
Yeah, for sure. Well, so glad to be here. So I, as Jan mentioned, I'm an OB/GYN, and when I was in private practice for about 8 years after residency, and had lots of patients with, who were running the gamut of issues that they needed help with, but something that was coming up a lot in my practice were sexual health challenges. For example, low desire, painful sex, trouble with orgasm, trouble with arousal. And I had literally zero training in any of these issues. And so I joined a sex medicine society called ISWISH, which stands for the International Society for the Study of Women's Sexual Health, became a fellow of that organization, and really learned that sometimes women, all we need is information. We need to know what is wrong. We need to know the evidence-based ways to get help. But that conversation, that, those resources are just lacking, and I couldn't really find anything to help my patients. So because of that, left private practice and started Rosy, which is a platform, an app that women can download on their phone. And we have, lots of resources, from education to community like Janice created to, anyway, lots of behavioral interventions to help women with sexual health problems. And one of our, loudest and most enthusiastic groups of users have been, survivors and thrivers. So we're really excited to have created content specifically for that community of women as well.
Yeah, I just read something the other day, which not evidence-based, but I read that, okay, every woman goes through menopause, but
yeah,
the indication, what I read, was that women who have gone through breast cancer have more severe menopausal symptoms. Is that true to you?
It is. Yes, it's absolutely true. And the reason is because there's a difference between sort of quote unquote natural menopause and then these other types of menopause, whether they're medical menopause, so induced by medications we might be taking, or surgical menopause induced by the, sort of abrupt removal of the ovaries prior to the onset of natural menopause. So when you have a gradual decline in hormones, it's much different than when you have an abrupt drop off, which is what is experienced for many, especially if you're diagnosed, obviously perimenopausally, premenopausally, that is a whole other system. And two, it could be that you've stopped having your periods, but your hormones are still gradually tapering. And once again, because of a hormonal medication or because of a surgery, that drop off is much more abrupt. And those symptoms can be much more severe because it's not a gradual drop off, but an abrupt one instead.
Right. I mentioned to you, this would be a kind of casual conversation, so I'm not meaning to sideswipe you, but a DO friend of mine recommended this book, Estrogen Matters. Are you familiar with it?
Okay. I have not read it. No.
Oh,
who wrote it?
It's Dr. Avram Blooming, MD. He's a medical onc, and then a let me think about what she is. She is a social psychologist. And so his wife went through breast cancer several years ago. And as the story goes in the book, he was like, what's the rub about using estrogen when you've had breast cancer? And so he started to dig into the research, And it seems this is the Jan James version. I'm not an expert in anything. Don't believe me, you guys. Check out
Yeah.
your own research. You know the drill. But there's more than 50 pages of research resources in the book. And his thing was, there was a study that was done by the Women's Health Initiative over 20 years ago that was taken by storm by the medical industry. But his premise is that that study was really flawed, and that
yeah.
the way that the medical industry thinks about estrogen is, I'm not even sure what to say, flawed also. So what,
Yeah,
what
it's
is your, as a
misconstrued.
professional, what do you think of, and you obviously have worked with many women that have had breast cancer, and you're not an oncologist, I get it,
Right.
but
I'm a gynecologist. Yes,
right,
for sure.
right. So let's just
Yeah.
make sure, but what is, can you weigh in on that?
100%. And I mean, I'm so, we talk about this in medical communities a lot, particularly in the sexual health community. And the conversation, I think, is becoming more prominent in the breast cancer community as sexual health becomes, a bigger area of focus for survivors and thrivers. So I love that you know about WHI. I love that this book exists. And clearly I do need to read it because I am on board. There's a lot of interesting sort of fallouts that happened as a result of WHI, this big study that you're talking about. And it's interesting. And the reason that a lot of the data is not applicable to most of us is those of us who are going to go through natural menopause, breast cancer survivors and thrivers, because they looked at women who were more than 10 years out of their menopause in this study, right? So they looked at 60-plus-year-olds. Average age of menopause, if we're talking about natural menopause, is 51. And then they look to say, okay, so if you think about estrogen particularly, so estrogen, then menopause for 10 years, right? We're getting down to very, very low levels of estrogen at that time. And then they all of a sudden add back estrogen for these women. And they did notice an increased risk of heart attack, stroke, and also breast cancer, right? But what they didn't look at was for women who had already had those amount of hormones, and all we're doing is just adding them. So at the time of menopause, when your hormones start to decline and you start to become symptomatic, what happens if you just add the hormones then? Right? What we know now is that there's definitely some adjustment that happens during this 10 years, right, between when these women had their natural estrogen, went down to very low levels, and then were added back this synthetic estrogen. But what happens if we do it at the time of menopause? And those questions were not directly answered. So for many of us who focus on sexual health, who focus on the care of women and know how substantial the symptoms of menopause can show up in all of our lives, we want to really be critical about that data and say, okay, none of us want to increase the risk of heart attack, stroke, or breast cancer, but we also don't want women to go without evidence-based and proven therapies because of some unfounded fear. And so that's really it sounds like what that book is about, what a lot of us, particularly in sexual medicine, but also OBGYNs as a whole, think, hormones, they're not like the magic bullet for everything, but they also are not like the devil reincarnate, you know what I mean, that should be avoided at all costs. In my opinion, this is like my entire take on medicine and on women's health particularly, is that women should be armed not to get into other things, but should be armed with the data and the facts, and then we let women make the decisions. Not all, I know it's crazy, not all breast cancer survivors are going to want to take hormones, and that's completely fine. Some of them, maybe after reviewing the data, will want to take hormones. And that should be an option as well, right? And so I think we need to lead less with fear, more with data, and offer patients the options available to them, and then participate in what we call in medicine the shared decision making, which is to say, hey, here's what I know as a physician, here's how that might show up in your life. It's your life. There's plenty of women, and I mean, I'm a part of your group, and I really appreciate that opportunity, who's I can understand, and the women that I treat and see all the time, it's like, if this is my version of life, like, this isn't for me. Like, this isn't it. And so I think we really have to listen to that information and really, meet women where they are. There's particularly really strong evidence to suggest that vaginal hormones really are really pretty safe in breast cancer survivors and thrivers. So it's two different ways. There's lots of different ways, but there's some systemic hormones. So those are just hormones you might take by mouth or put on your skin as like a cream or a gel or a lotion. And then there are hormones that truly just go in the vagina. And there's lots of data to show that those hormones that go in the vagina stay locally. They don't go throughout the body. So if you have, hormone receptor positive breast cancer and, you're scared about taking hormones, vaginal hormones could be an option, especially if you're experiencing painful sex, vaginal dryness, all those things, because those hormones stay in the vagina and shouldn't increase your risk. What's interesting is that many of us in the OBGYN community feel this way, but it's the oncology community who we're really having to show the data to and say, hey, so it's really great that an oncologist has written this book. Another person in the sex medicine community who you should connect with, Jan, I'll be happy to connect you with, and maybe any of your community who are on Twitter, is Dr. Rachel Rubin, Rubin. And
Okay.
she is like a warrior for, cancer survivors being able to take vaginal estrogen, and really feels very strongly that all oncologists owe that option to their patients, no matter hormone receptor, status. And it should be on the table for everybody. So I
Wow.
think it's worth a discussion. Sometimes it's hard to get your OBGYN and your oncologist on the same page, as I'm sure many people in your community have experienced, but
Mhm.
it's certainly worth, a really hard look at the data and opening up that conversation for sure.
Right. Thank you. And you know that I would love that introduction to Dr.
Yeah.
Rachel. That's awesome. And whoever else you feel you because you're part of our community, you know the struggles that our women have. And it just is,
Oh,
it's so heartbreaking for me, which is why you started Rosy Wellness. I understand that. So
absolutely.
yeah.
Yeah.
Uh I also want to just say, like, not to get like TMI-ish, but I have really severe vaginal atrophy, and I'm 10
Yeah.
years out from ER positive cancer. And so, based on my old PCP was the one that told me to read the book. And she was the
Yeah.
one that I interviewed last week. And and she's the same as you. It's not for
Yeah.
everybody. It's not that thing. And in
Right.
fact, she and I talked just about my personal situation. Being 10 years out is
Yeah.
probably a safer time to be able to take vaginal estrogen than, you'd really have to weigh your options if you were still in active treatment or just out of treatment. So 10 years out is a different story. So we have to
Sure.
just be armed with the information. And so I do have um, an appointment in July with my gynae, who has also read the book and said she's really prescribing a lot more vaginal estrogen for women.
Oh, I
So
love that.
I know. So anyway, I
I'm
may,
gonna read the book and talk about it, because
oh,
if we
it's,
can get, yeah, if we can get systemic change amongst providers, that will make
mhm.
such a huge difference. So
Well,
that's awesome.
and Lynn's, listen, I sent the book by Amazon to my aunt, and she's from
Mm,
the research side of the house, right? And she knows what our groups are all about and everything. But she was the one that really pounded into my head. I love her. I love her. She saved my life.
yeah,
But she said, estrogen fed your cancer. She was the
right.
one that gave me the words that were ingrained in my brain.
Sure.
So reading this book absolutely like turned everything on its head. And I went, okay, now wait a minute. If that
Yeah.
study was flawed, and now I'm just questioning things. So I asked her when I sent it, I just wrote a note and said, would you look at this from a research standpoint? There's more than
Yeah.
50 pages of research studies in the back of the book. Weigh in and let me know what you think about that. So we'll see. I think that you're right that change, or what I mean, helping the oncology industry
Yeah.
understand what's going on with hormones is really the harder job right now. So,
Well, and honestly, you can't blame anybody. I mean, after WHI, it was all over the media. Women
oh,
everywhere wanted to stop hormones. Doctors everywhere stopped prescribing because they were scared they were going to get sued. Like it's not as if oncologists have a bad agenda. They truly want to save lives. You know what I mean? And
totally.
it's just all about, like, let's take a step back. Maybe there's a different way to look at this. So I'm sure that your oncologist loves you as much as you love her, because you're
Mhm.
helping her to think about things in a new way, in a different way. And that's what practice, right? As a physician,
Right.
that's what practice is all about. It's never done. We never have it perfect. We're always learning from our patients, from their specific and set of circumstances, and also the research. That's the thing about science, is it's never final. There's
Right.
always new information coming out. So, I think it sounds like a great relationship that y'all have. That's
Yeah,
exciting.
no, totally
Yeah.
do. And, yeah, I'm really grateful for her too. So yeah, I'm looking forward to hearing. I'd love you to come back and weigh in on the book after you're able to read it, because
Yeah.
it will get, I think, based on what you're saying right now, you'll really enjoy the way that they went about it. I said in my article, I'll send you the article that I wrote and the other interview, but I said it reads like a thriller. I mean,
Oh,
the
love
introduction
that.
is called "Who Killed HRT?" And it was like,
I
ooh,
love it.
okay. And I
Yeah.
love
It's a
mysteries,
mystery.
and it really is, it's a great read for laymen like myself or professionals like you. Either way, it works. And so I enjoyed the read. I was a little disturbed by the read because of some of the things
Yeah.
that were posited there, but I think it's a great way to look at new information. So that's good. So,
Yeah.
okay, let's get to
That's
the
awesome.
nitty gritty, girl. What's troubling our community. And,
Yeah.
the two biggies are lack of libido and painful intercourse. So let's
Mhm.
talk about libido first. What are you finding are the new and the good ways to go about libido? We've got a bunch of, we've got, I think, 26 contributing experts now, many of them counselors, some of them sexual counselors, I'm glad to say. So they're
I
bringing
love that.
their knowledge to the table, which we've been publishing on our blog. And we have a brand new podcast as well, everyone. And so from that perspective, that helps. But from a physical standpoint, what can you tell us about lack of libido?
Gosh, so this is something that I have focused on for the past few years is sexual desire. And it is I hate this phrase that it's complicated, right? Because I think that allows us to get off the hook rather easily, and I don't want anybody to get off the hook when it comes to sexual desire, but we'll say it's multifaceted. Okay?
Mhm.
Maybe that's a more respectful way to describe it. And that's the case for men, that's the case for women. There are so many factors in our lives that affect the way that we feel about sex and the way that we feel about having sex. I would say, whenever we think specifically about breast cancer survivors and thrivers, there's so many different aspects from the stress of, facing that diagnosis. What does that mean in your life? How does that change, all the many aspects of your life and how you think about your time, here on earth? All the way to, so from that, like true, I would say like mental, crisis, all the way to the actual physical changes that happen with your body, right? So we've heard from so many women that just feel sexually disconnected from their body because the way that their breasts look and feel to themselves internally has completely changed. Obviously, sex is painful, so that nobody wants to stick their hand in a hot fire over and over. Nobody wants to have painful sex over and over. There's lots of dynamics with partners, right? So there's this idea of like sex itself, but then also our thoughts about sex or our metacognition about sex, like thinking about sex. And how do we feel in our own bodies? How do our partners feel about us in this, new or changed body? Are we, is everything functioning like it was before? So you can understand that this like swirl of, change from all the way from the mental side to the physical side. And then we can't forget the relational side, and it's all happening at once, right? And the challenge with it all happening at once is that before your work, Jan, and before some of the work that we're doing, there was nobody there to talk to people about it. They were literally all just figuring it out, or not figuring it out, more likely for themselves, and feeling like because there was no conversation about it, that they were the only one that must be suffering with these issues. Like clearly, if everyone were experiencing this that had breast cancer, we would be shouting it from the rooftops because it's unacceptable. Just like when men go in and have, surgery for prostate cancer, that's the very first conversation they have with their urologist is how they're going to maintain their erection. But where is that conversation on the breast cancer side of things, or on the, uterine or ovarian cancer side of things, or cervical cancer? It's not there. And that's just
100%. Yeah.
yes, it's so frustrating. And it's another way that we dismiss women's experience of their sexuality, and it's just not, we can't stand for it, right? So that's why I appreciate so much just the opportunity for women to come to your community and just share their stories. I mean, I think there's something, and actually it's been demonstrated that there's something so therapeutic about knowing that you're not the only person facing these issues. And isn't this an outrage that we are all experiencing the same thing and nobody is addressing it? So I think, when we really take a step back and think about all the different things that people with breast cancer are facing, we can understand how that has an effect on their sexual desire, right? And I think that level of understanding, and potentially even that level of patience with ourselves during that process, is such an important piece of things, right? You wouldn't expect someone else, your best friend, to go through a similar circumstance and be like ready to rock and roll from a sexual perspective, right? Everyone can understand what a major shift in sort of life, that this is, and that more than anything, in order to get through at least the acute phase, we need to have a lot of patience with ourselves. We need to ask for that from our partners. But when it turns to a time where we start to want to work through those feelings about our new bodies, about the way that our bodies function sexually, about our thoughts about sex, then I think it's important to know that there are resources, right? So it's not as if, day after surgery, you have to start to work on your sexual health. But when you're ready for it, it's there for you. And I think that that's an important piece of this, is like, if you desire these resources, if you want to work on this aspect of your life, then there are resources available. And something that can be, we have to definitely talk about painful sex separately, because
Yes.
oftentimes desire for sex and painful sex are together, but we can never address desire for sex if someone's having painful sex. We must first address the painful sex. So I want to say that as like a ground rule. If someone's having painful sex, we cannot expect them to be desirous of sex. So we have to address the pain first. But let's assume that painful sex is either not there or has been addressed, and we can talk about desire. So there's this idea that happens for many women, especially women who have, been through, I would say any, health affecting condition, and this idea of responsive desire. And it's super duper cool to think about. So if I had some charts, I would pull them up, but I don't have them. But we think about, so Masters and Johnson, whenever they were studying sexuality back in the 60s, they brought people into the lab. They literally observed them having sex, and they kind of wrote down the different phases of sexual response that they saw. And what they charted down was arousal, which is happening in the genitals, right? So that's, for men, that's erection. For women, the same thing actually happens in our genitals. The clitoris gets engorged, the labia get engorged, there's extra blood flow, right? We can feel pulsing and throbbing potentially in the pelvic region. So that's arousal, and it's a physical response, right? And then there's this idea of a plateau, and then there's orgasm, and potentially, 2 or 3 or whatever orgasms. And then there's this idea of resolution. But when Masters and Johnson were looking at it, they didn't even consider where desire might go on this pathway. And then several years later, about a decade later, another sex researcher put desire kind of on the front, because it seemed like desire might come before all of this other stuff. And that's how a lot of us are sort of think about desire, generally speaking, is that desire must come first, right? Like, I must be desirous of sex, having spontaneous sexual thoughts or fantasies before, engaging in sex. And that's the definition of having like an active and, I would say, healthy desire level. And that's actually not true. So another sex researcher named Rosemary Basson came along in about 2001 and actually described that her patients oftentimes had her clients, I should say, had what's called responsive desire. And what that means is that, just kind of like going to the gym, like sometimes I really would rather not. I'd really rather just like eat popcorn or drink wine and sit and watch the next episode on whatever's playing on Netflix. But if I get to on my Peloton, which I'm obsessed with, and I work out for 20 minutes, I'm like, yes, like why did I ever think about not doing this? This is like exactly what I needed. And the same is true with the path of responsive desire for many women as we age, for some women throughout their entire life. And this is the case for men, it's for some men as well. And it's totally normal. But it means that sometimes we need to actually start engaging in sort of some intimacy acts, or sometimes we need something to kind of get this pathway kickstarted for us. And on Rosy, we use erotica in this way, where you might log on and read a sexy story, and that sort of gets the arousal in your body kicked off, and then comes the desire, right? So one of my favorite sex therapists, her name is Laurie Mintz, and she's been very active on Rosy, and then also she's written 2 books. One is called A Tired Woman's Guide to Passionate Sex, great read. And she talks about and she uses the word horny. So you'll have to forgive me if that's
That's
offensive to anyone,
fine.
but she uses
We
the
all
words,
know.
yeah, she says, don't wait to get horny to have sex, but have sex to get horny. And that's a tried and true, path. And what it involves is lots of lubrication, lots of things that are arousing to you, right? So I think many of us have this script of like, oh, there's some amount of quote unquote foreplay, which is not the way that we like to talk about it in sex medicine, because it's all play, it's all the same. And then you go directly to, this heterosexual version, penis and vagina sex, right? And that's like the main course. But for women, that's just not the way it goes, right? Many women most, in fact, 85% of women have orgasms through clitoral stimulation. So when we're not talking about that, when we're not practicing that in our sexual scripts, then we're missing out on the opportunity to become aroused, to have, as many orgasms as our partner, and really to feel desirous of having sex, with anybody else. Research shows that when, women self-pleasure, they have orgasms very reliably, pretty quickly, like it's not a thing. But when you introduce a partner, that orgasm number goes down, because we're relying on penis and vagina sex to, stimulate an orgasm. And that's just not the way it is for men. So when we back out, we can say, okay, we know that sometimes arousal comes before desire. That's called responsive desire. It's actually a very normal way to experience sexual desire. And we might need to really tap into that to accomplish our sexual health goals. So if you found that desire has kind of gone out of the window and your goal is to increase that, then you can use erotica to increase that. You can use, you can schedule sex, which is sort of an old tried and true sex therapy recommendation, in order to have sex, to feel desirous. And those are some tricks that I think can move women out of feeling like something's wrong or pathologic with them, into really becoming empowered and feeling in control of, how and when they feel sexual desire. But once again, none of those tricks are going to work if you're having pain with sex. And there is a certain subset of women that qualify for a diagnosis, about 10% of women with hypoactive sexual desire disorder, or HSDD. And I'm sure, honestly, I don't know the data in breast cancer patients, but how that, overall general incidence moves, and I would assume increases in breast cancer patients. But those patients, the neurotransmitters in the brain that usually fire to create that desire are no longer functioning. So just like in depression or anxiety, the neurotransmitters to create, those feelings that we associate with positive, feelings are not firing. The same can happen with sexual desire. And those patients could qualify for a medication to potentially help increase the neurotransmitters that then can increase desire as well.
Right. I appreciate you just discussing arousal versus desire and such. For so many of us, myself included, pretty much in the old days, many years ago now, arousal was 100% based on my breasts. And now that I don't have breast tissue anymore, it's like, well, okay, now what? And so,
Right.
do you have suggestions? This may be more of a sex therapy question, but do you have any thoughts about that, about how to switch your arousal process when you don't have breast tissue?
Yeah, I think it's interesting because, every person that you talk to is going to describe their arousal experience differently, right? And not only is it where is arousal showing up in our body, but also where are we most cognizant of that arousal, right? And so for you, I would venture to say that your experience of arousal was breast focused, but I would also hypothesize that there is a genital response as well. And so what I would counsel, and this is coming straight from my sex therapy colleagues, is to really try to practice. And this is like so cliche, but honestly, if we cannot be mindful and present in our bodies during sex, during arousal, during orgasm, it's never going to happen.
Right.
And that's a struggle for so many of us, right? Because I'm stressed about what alarm is going off and all the emails that I didn't respond to. And oh my gosh, I left laundry in the washing machine. And, whatever is my, child going to try to come in the room? We all have those lists of worries. And if we cannot focus on where exactly are we experiencing pleasure in the moment? Where exactly are we experiencing that arousal? We're never going to get to the place where we're more than just a passive participant in sex, right? If
Right.
we want to find pleasure, if we want to find arousal, we have to sort of really go inside ourselves in the experience and say, in my genitals, right? In my labia, in my clitoris, in my pelvic floor, am I feeling these sensations of throbbing? Am I feeling like a sense of heaviness? That is a genital arousal. And so I would say in breast cancer patients who, maybe you're used to experiencing that in your breast, and that's an erogenous zone for you. So not only are you getting that feedback from your breast, but also that external stimulation to your breast is sort of feeding into that potentially there's an opportunity for, experiencing that same thing through genital arousal with shifting that focus. That's not
Right.
to say that a sex, therapy colleague might not answer that question much more eloquently and scientifically than I have, but that's what I've learned, from creating content with a lot of them over the years.
Right, right. Well, I am relatively confident that you saw somewhere along the line over many, many months now, let's see, the fanfare that's been caused by the Rose vibrator, that
Oh
has
yeah.
swept through our community, and in
Yeah.
in homage to to Rosie, right?
Yeah.
But
Yeah.
yeah, but I think that has been such a successful way for women to understand that they can orgasm again, where they thought
Absolutely.
it was dead, that was it. And I
Yeah.
just encourage them to use that with a partner to be able to figure
Totally.
out different ways to make it work. So yeah, so that's good. So on the painful sex thing, I'm so with you. And in the work that I have done personally, body before brain is what I have learned,
Yeah.
that we need to take care of what is physically happening with us,
Hmm.
before we can get our brain engaged in having the desire to have sex. And so, are you in agreement that women should really talk with their gynae about what's happening so that they can get input on, do they need to see a pelvic floor? I have to tell you, my like really number one, I'm going to call it frustration, it's just more heartache, is that women
Yeah.
come into the group now, we're 9,000 plus women, right? Women come into the group and are just going, what lube do I use? Well, guess
Right.
what? That a lube
Yeah.
is not always the answer. And so,
Right.
can you weigh in on that?
Totally. Yeah. I mean, I could not agree more. And I think that, starting those conversations with a healthcare provider who is, who's listening, who is competent, who is really wants to help you live your best life, I think is definitely the key to unlocking this whole thing. Lube is for everybody. I mean, I'm obsessed with lube, but that's not, to your point, that's a band-aid, right? Like that's not going to help if you have vaginal stenosis or if you have severe atrophy or if there's a lot of things that lube is not going to help. Lube can definitely increase pleasure, and it can also be great, but it's not everything, right? And so I think you're right that for access to the rest of those resources, which in some cases could be vaginal hormones. I love vaginal DHEA. So what happens with DHEA is it gets changed into estrogen and testosterone in the vagina and the vulva, and there are testosterone receptors on the vulva. There's actually, interestingly and nonsensically, there's no black box warning on DHEA because it's not an estrogen containing product, but it gets converted to estrogen in the body. So
Oh, wow,
whatever.
that's
But
interesting.
it just shows you the lack of attention that
Yeah.
I think it actually gives more weight to the idea that the vaginal estrogen is fine to use as well. But anyway, that's a different conversation for a different day. But so vaginal DHEA can offer the estrogenic effects in the vagina, but also the testosterone effects as well, which can positively benefit sexual outcomes as well. So that's always, I think that's worth a conversation. I think to your point, pelvic floor physical therapy is always, a wonderful partner to have adding to the conversation a sex therapist, or we have on our platform sex coaches, which are super valuable. And then, there's all kinds of other things as well. Some people I know on the platform have talked about laser therapy. Those reviews are mixed, and the data is mixed as well. We don't have like large studies in cancer patients, so I think we have to approach with caution. But the key to unlocking the door of options is to be able to have an informed conversation with a passionate, dedicated, healthcare provider. And I know how difficult those conversations are to start. Sometimes you're like, okay, I'm going to talk about it. I'm going to bring it up. And people are just like you cannot get the words out of your mouth. It's really difficult. And so actually on the platform, we created a PDF that you can print out and take with you to your healthcare provider and just circle the things that are wrong and then physically hand it to them, or the nurse if you prefer to speak. Sometimes you have a closer relationship, especially in the oncology world, with the nurse because you just are interacting with them so much. So, whatever we can do to facilitate those conversations. And also on the OBGYN side, whatever we can do to increase the competency of OBGYNs in talking to their patients about sexual health concerns is also a huge part of my personal work. And part of the whole equation, because many of us, like I said, are not trained in these areas. And so we get a little nervous. We're like, oh, ask your oncologist. We don't want to hurt you. Or, or maybe they don't address it because they just feel uncomfortable. So there's a lot of work to be done on both sides. But I would say, if it's an issue, which for many people it is, and it should be addressed already, but if it's not been addressed, then definitely starting that conversation is a great place to go.
Great. Well, from a gynae standpoint, this just came up again. And so this was great timing that you and I were going to talk today, but what in the world is that razor blade feeling that happens? So that to my mind, it's a post-menopausal or during menopausal issue, right? Where the tissue has become so thin. Is that part of it?
Yeah. Are you talking about during sex?
During sex,
the razor blade feeling?
Yeah. And even sometimes some vaginal spotting and that kind of thing that happens. So.
Oh, right. Yeah. So what's happening is when the estrogen goes away, right? Either we've gone through menopause and it's gone down, we've had our ovaries removed and it's gone down, or we've started some hormone receptor blockers and it's gone down. The tissue of the vagina has hormone receptors, right? Has estrogen and, as I mentioned, testosterone receptors. And without that estrogen, the tissue goes from like a nice, I'm thinking of this because it's summertime in Texas and we can't get out of the pool, but like a nice, like inflatable, like I can handle some extra pressure in the vagina. I'm nice and, lubricated to handle some friction in the vagina, to thin. So like the inflatable has deflated, and also there's no lubricant. So it's dry, it's thin. So when there's a lot of friction there, sometimes even with lubricant, you're gonna feel, it's not gonna feel good, right? And because that tissue is thin and because it's not able to withstand that friction and it's no longer lubricated, you get these little micro tears, and that's when you notice bleeding. And it feels like shards of glass.
Mm-hmm.
Nobody finds shards of glass not that I know, to be pleasurable.
Bueno.
And along with that, along with the painful sex comes increased risk of urinary tract infections, comes increased risk of vaginal infections, because we're no longer able to support the good bacteria that love the estrogen that live in the vagina. So, I have not had breast cancer, I will say, but you can bet that if I don't have a strong reason not to be on vaginal hormones for the rest of my life, I will 100% be on them because of all of the negative side effects of not having estrogen in our vagina. Painful sex, increased urinary tract infections, increased vaginal infections. And also when we lose that extra buoyancy in the vaginal tissue, it loses its elasticity. So the uterus starts to come down, the vagina starts to fall a little bit more. So that idea of prolapse is increased as well. So many reasons to keep the vagina estrogenized. But once again, it's an individualized discussion. I'm nobody here's doctor. I'm just sharing with you my my opinion and my experience.
Right. No, that's awesome. So let's talk a little bit about what we really want to encourage everyone to go and download the Rosy app. And I hear that you might have a little gift for everyone.
Yes, my sweet Haley, who is on our team, created a special code for your audience. And if you go to meetrosy.com/promo, then there is a 1-month free subscription to the silver membership, which is basically all of our content. So it's a personalized sexual health plan that includes specific content for breast cancer survivors and thrivers, made by an oncologist who specializes in survivorship and her clinical nurse psychologist, erotica specifically for breast cancer patients that doesn't mention breasts or nipples, and then community support as well. We can't compete with your community, Jan, so I'm not even going to put that out there. But maybe your users can come in and recruit our community users over to yours, because I know yours is bustling. But yeah, it's good for a free 1-month subscription to the silver membership, and the code is HOPE, capital HOPE. It's good for new subscribers, and also Rosy is available in the US and Canada. So I'm not really sure about the geography of your community, but Rosy is available in the US and Canada. So I'd love for as many of your community who want to come and check out what we're up to, and really, I have loved everything that you've been about since day one, because truly we're on the same mission. And to see your success and see you grow, and your passion, that I know it's hard work, but your passion is undying. So it's inspirational, and I'm so happy for you. And I know that you know what a big difference you're making for all the women that are in your community. So powerful.
Yeah, really privileged to be able to be in this role to help bring solutions to the women that I care for so much. So thank you for that, though. And you're one of the reasons too, being able to have professional experts in so many disciplines that have come alongside us has been really a huge blessing. So appreciate that very much. Well, that's awesome. Well, that is it for me for today. And is there anything else you want to share just in closing, Lyndsey?
No, I just appreciate you spreading evidence-based information and, giving women hope that you're talking about. So thanks so much for your work, and thanks for having me today, Jan.
Thank you. Thank you. There is hope after breast cancer. That's what we want to pound into everybody. So that's awesome. Well,
Absolutely.
Thanks so much for taking the time, and I will chat with you later. I hope that you read that the Estrogen Matters book, and
I will.
We'll stay in touch about that. Okay.
Sounds good. Thanks,
okay,
Jan.
Thank you so much for chiming in on everything. Thank you, Lyndsey. Take care.
Okay. Bye-bye.
Bye, everyone. Bye-bye. Girlfriend, thank you so much for listening to our podcast. I hope you found some nuggets to encourage you and give you hope. Make sure you subscribe to the podcast. You never want to miss an episode. And we'd love to know how we're doing, so please be sure to leave us a review. Until next time, this is Jan James encouraging you to remember there is hope after breast cancer. See you next time.